Unexplained pain is one of the most common and challenging clinical presentations. Many patients arrive with persistent symptoms, normal investigations, and increasing distress. The key question is not whether the pain is real. The real question is why the nervous system continues to generate danger signals despite the absence of structural pathology. To understand this, we begin with the primary circuit, interoception. Interoception refers to how the brain senses and predicts the internal state of the body. The core loop involves visceral afferents from the brainstem, relayed through the thalamus to the somatosensory cortex, and integrated within the insular cortex. The posterior insular processes raw bodily signals, while the anterior insular generates predictions about what those signals should mean. In unexplained pain, the system is not failing to detect sensation. Instead, prediction error remains persistently high. The brain keeps expecting damage or danger. Normal physiological signals are therefore interpreted as abnormal. This is best understood as a precision weighing problem within predictive processing. The brain assigns excessive importance to internal signals, amplifying their subjective intensity. Clinically, this presents as vague or shifting pain, poor anatomical consistency, and symptoms that worsen with attention, stress, or fatigue. Patients often monitor their body closely and may also report gastrointestinal discomfort, palpitations, or dizziness. It is essential to emphasize that this is not malingering. The experience is generated by real network dynamics. Once interoceptive signals become noisy, the brain recruits a secondary system, threat circuitry. Structures such as the amygdala, bed nucleus of the stria terminalis, periaqueductal gray, and hypothalamus evaluate whether the body is in danger. When threat is engaged, autonomic gain increases, bodily signals become more salient, pain thresholds decrease, and extinction learning becomes impaired. This creates a self-reinforcing loop. Interoceptive noise triggers threat interpretation. Threat increases autonomic arousal. Arousal amplifies bodily signals, which are then interpreted as further evidence of danger. Over time, the nervous system learns to remain in a defensive mode. Consider a clinical example. A 34-year-old school teacher reports intermittent left-sided chest and shoulder pain for 2 years. Cardiac evaluations remain normal. The pain fluctuates with stress and improves during distraction. Associated symptoms include bloating, insomnia, and episodic dizziness. The patient frequently checks pulse rate and seeks repeated reassurance. Mechanistically, this pattern reflects persistent interoceptive prediction error with secondary threat amplification rather than progressive disease. At the bedside, you may observe autonomic instability, fragmented sleep, and marked variability in symptom intensity. Investigations are often normal or only incidentally abnormal. Recognition comes from pattern synthesis rather than exclusion alone. A useful formulation is this: persistent interoceptive prediction error with secondary threat amplification leading to sensitized pain autonomic loops. This formulation guides intervention by identifying leverage points. We aim to reduce excessive interoceptive precision, decouple threat from bodily sensations, improve autonomic recovery, and restore sleep regulation. When unexplained pain is framed as a network-level process rather than a mysterious symptom, clinical decision-making becomes more precise, less adversarial, and more therapeutic for both patient and clinician.